think it's very important for us to thank Professor Ahmed Al-Judayf for his kind invitation to us to participate in this symposium, and Dr. Hajar, of course. And the organization of the symposium, as you can see, is excellent. So special thanks for all the organizers, Ms. Fatma and all the group. I'll be talking about osteoporosis, where are we now? So that implies that I'm going to take you through a journey for osteoporosis all days till our date today. There will be important milestones during this journey, which I'll be going to touch on. Most of them are very important and very crucial in our understanding, diagnosis of treatment of osteoporosis. I think it's fair to say in the beginning that osteoporosis is an old disease. It is not a disease of the current culture and the current days. And in these excellent studies that were done on skeletons that were excavated from the cemeteries, al-madafin, of the old pharaohs near the Giza pyramids. Now, apparently, the pharaohs used to have two types of cemeteries. Cemeteries for the high officials and cemeteries for the workers and the general population. So they were able to excavate 73, I think, skeletons from these cemeteries, and they were able to do dual photon absorptiometry on these skeletons. And to account for the muscle and the flesh and the soft tissue, they were putting rice bags in these areas so that the attenuation of the beam of the X-ray can be taken care of. And at the end, they were able to show that there was more evidence of osteoporosis in the skeletons that were taken from the high official cemeteries as compared to the workers, perhaps reflecting the sedentary lifestyle of the people in these cemeteries. More osteoporosis as people are elderly, more osteoporosis in females than in male population. Prof. Ahmed has already spoken about the impact and the burden of the disease, as you can see in this slide, comparing osteoporosis, osteoporotic fractures with very important other diseases such as cardiovascular disease, stroke, and breast cancer. And you can see the difference and the impact on the patient's morbidity and mortality. So these are points that were raised by Prof. Ahmed, and no need to repeat them. Now, in terms of the diagnosis of osteoporosis, when I was a medical resident, even when I was a medical resident, diagnosis of osteoporosis was based on the ordinary X-ray. And if you do a chest X-ray, for example, or you do a vertebral spine X-ray to look for a fracture or something, the radiologist will tell you that there is osteopenia. And the radiologist will not be able to tell you that there is osteopenia until or unless at least 30 or 40% of the bone mineral density of that piece of bone has been lost. And that is, of course, not very satisfactory because you do not want to diagnose osteoporosis very late. Now, the first attempt to measure bone mineral density by a technique which is called single photon absorptiometry. And in this device, it's a small device. It's probably the size of the radio of your grandfather. It measures the bone mineral density in the forearm. And it's a beautiful device, and we acquired it a long time ago, and we even published a paper on the prevalence of osteoporosis among patients that we saw, Professor Dessougi and the group, and that was the first paper perhaps on the prevalence of osteoporosis in Saudi Arabia. The dual X-ray absorptiometry was invented in 1987. And currently there are three companies that produce their machines, the Hologic, the Lunar, and the Norland. And indeed, this machine and this technique is a very important step and milestone in the management of osteoporosis, because for the first time we were able to diagnose osteoporosis based on the deviation of the T-score of your patient from the young adult population. And in 1994, the World Health Organization were able to define different grades of bone mineral density, starting from normal to osteopenia or low bone mass, osteoporosis, and established or severe osteoporosis. So this is a very important slide. It emphasizes a very important step in the diagnosis of osteoporosis. Now, in the younger population, namely premenopausal women and men below the age of 50, we use what we call a Z-score or a Z-score, which takes care of the comparable age group that is to your patient. And of course, traditionally, we measure the bone mineral density in two sites, the lumbar spine, L1 and L4, and the femoral neck. In special circumstances, you may need to depend on the bone mineral density in the forearm if the other two sites are not suitable for the diagnosis. Now, with regard to the treatment of osteoporosis, and until perhaps when I was again a medical resident, there was no satisfactory treatment for osteoporosis other than calcium and vitamin D. But we know that senile osteoporosis and postmenopausal women is related to the loss of the sex hormones. And for that reason, estrogen used to be used for the prevention and even the treatment of osteoporosis, because estrogen has got very important pharmacologic effects on bone. It improves the osteoblastic activity, and it seems to reduce the bone resorption process. So estrogen appeared to have a very promising role in the prevention and treatment of osteoporosis. However, unfortunately, a very important paper came in JAMA in the year 2002 by the Women's Health Initiative randomized group, and they have found that there was unfortunately an increased risk for breast cancer, stroke, and cardiovascular disease in women who took estrogen. The type of estrogen that was used in this study was conjugated estrogen, and there was also an increased risk of venous thromboembolism. So that was a very important study. In fact, this study was cited by 6,000 people. It's probably one of the highest citations that you can see in the area of osteoporosis. So unfortunately, we do not use estrogen as the first-line treatment for osteoporosis. But if the patient happened to have significant postmenopausal symptoms and she was given estrogen by her gynecologist, the estrogen certainly is going to protect her bones to a good extent. It was realized over time that the way to treat osteoporosis, and based on the process which we call remodeling or bone turnover, is either by stimulating the osteoblast to produce more bone or by reducing the issue or the process of bone resorption. So that was the understanding in the beginning, and based on this, the different types of medications were introduced over the years. And the eldest one, if you like, is calcitonin. And calcitonin was used in an injectable form in 1986 and in the nasal spray, which was introduced in 1995. And as a matter of fact, I have used nasal calcitonin for my patient for a few years. And unfortunately, again, there was some evidence that there was an increased cancer risk in patients who have used calcitonin. So calcitonin, which at the end of the day is a weak anti-osteoporotic treatment, was withdrawn from the world markets. In 1995, alendronate was introduced, and that was again a very important milestone in the treatment of osteoporosis. It's a bisphosphonate, as you all know, and it works by reducing the resorption process in the bones. Initially, it was in the form of a daily use and daily dose, and we have used it for a number of years. And then came the 70 milligram weekly dose, which was approved by FDA in the year 2000. Raloxifene came in 1997. It is good only for vertebral osteoporosis. It is particularly useful perhaps for perimenopausal women, but again it has some adverse effects in the form of increased incidence of thromboembolic events and possibly hot flashes. It seems to have some protection against invasive breast carcinoma. So if your patient happened to have a family history of breast carcinoma, you might want to consider this treatment for hair. Teriparatide is a very important milestone in the management of osteoporosis, because here you have the first anabolic agent for the treatment of osteoporosis. It's a parathyroid hormone analog, and it works by improving the anabolic state of the bone. And this is some beauty of endocrinology. When you have a hormone like parathyroid hormone, if you give it in a sustained continuous pattern, like in primary hyperparathyroidism, it causes osteoporosis. But if you give it intermittently, like these daily injections, it seems to improve the bone situation. It is usually given for a period of 2 years. These are the usual guidelines. Special exceptions do actually exist. And it is usually reserved for people with severe osteoporosis or people who have developed fractures while on bisphosphonate treatment, for example. It is contraindicated in patients with hyperparathyroidism, of course, and for people with history of radiation and skeletal metastasis and Paget's disease of the bone. Strontium ranelate came in the year 2005, and in the beginning it appeared to have a very promising role in the treatment of osteoporosis. However, again, unfortunately, it was linked with cardiovascular events, so it was withdrawn from the market. Another bisphosphonate parenteral is andronic acid, came in the year 2007, and then came denosumab. Denosumab is a fully human monoclonal antibody blocking the rank ligand, and in this way inhibiting osteoclast formation and bone turnover. So that was a very important step in the management of osteoporosis, because it is given every 6 months. The treatment is almost indefinite because of adverse effects on vertebrae when the treatment is discontinued. Abaloparatide, which again is another PTH analog, approved in the year 2017, and currently there is a transdermal form which is under investigation. I think perhaps it is currently approved in Japan. Now, 2 important side effects came out from the treatment of bisphosphonates: osteonecrosis of the jaw. The first case reports appeared in the year 2004, and atypical femoral fractures. So these two important adverse effects of treatment of bisphosphonates. The time does not allow to spend more time because there are so many details about the prevention and management of these conditions. Certainly for the atypical femoral fracture, this adverse effect seems to be related to prolonged use of bisphosphonates, typically beyond 5, 7, and 10 years. As you can see here, the incidence of atypical femoral fractures in patients treated with bisphosphonates. As I mentioned previously, denosumab, if it is discontinued, there seems to be a rebound, deterioration of bone density and acceleration of osteoporotic fractures in the vertebrae. So whenever denosumab is discontinued for some reason or the other, you have to replace the patient with a bisphosphonate to protect the bones from this adverse effect. It is given, as we said, every 6 months, and we usually inform the patient about the exact date for the next injection, so the patient does not forget this date at all, and the treatment is continued indefinitely, or at least for 10 years. And for, as I said, if needs to be discontinued, you replace with a bisphosphonate. Another important milestone in the management of osteoporosis is the invention, or if you like, the FRAX. The FRAX is a fracture assessment tool. It is to some extent like the cardiovascular assessment, which is based on computing risk factors. And here in the case of osteoporosis, age, sex, body weight, use of steroids, smoking, and so on. And based on these clinical risk factors, you will be able to tell the patient his or her 10-year probability of a hip fracture or a major osteoporotic fracture. And this is the tool which we use in our clinics. And as you can see, we put all the risk factors, and at the end you get the result of the FRAX, and that will tell you the 10-year probability of an osteoporotic fracture in your patient. Again, it was recognized over the years that that bone integrity or bone strength is not only the bone mineral density, but it also includes a very important issue, which is the bone quality. It is the bone quality, which means that microstructure of the bone, the geometry of the bone, and the trabeculae of the bone, they also have to be of good strength. And that, of course, will explain the definition that we use all the time of osteoporosis, which is a systemic skeletal disease characterized by low bone mass and microarchitectural deterioration of bone tissue. And therefore, there was a need to look for a macro architecture thing in the bones that we can measure or we can estimate. And newer techniques took place, the PQCT and the TBS, the trabecular bone score. These are newer techniques that will give you an idea about the integrity of the bone, the microstructure of the bone, and they can be of some use in your patient with osteoporosis. In the year 2019 came a new concept which is related to sclerostin inhibition. And as we know, sclerostin is bad for bones. So you would like, if you block that process, you'll be able to improve your bone formation. Romosozumab came in the year 2019, and it seems to have a dual effect, stimulating bone formation and simultaneously decreasing bone resorption. It is typically reserved for patients with severe osteoporosis or patients who have fractured while on previous anti-osteoporotic treatments. It is given monthly subcutaneously for 12 months. In the interest of time, I'm going to skip some slides. Few important studies were done in Saudi Arabia about the diagnosis and management of osteoporosis, and guidelines have been put forward for the treating physicians to manage their osteoporotic patients in terms of diagnosis and treatment. Now, in the last few years, there have been new concepts in the management of osteoporotic patients, and there has been a little bit of deviation from the classic traditional way of looking at the bone mineral density, and depending on the bone mineral density, you will give the treatment or you would not. And based on this, there have been attempts to stratify your osteoporotic patient with relation to the risk of fracture. So for the first time, we are not talking about osteoporosis as such, we are talking about fracture risk. And based on this, patients can now be classified into either having low risk of fracture, intermediate risk, high risk, and very high risk. Now, for every group of these individuals, certain amount of drugs might be most suitable. For example, patients who have low risk, you might be satisfied with calcium and vitamin D, whereas patients with very high risk, you might want to consider anabolic treatment, and so on. So this is a new concept in the management of osteoporosis that I thought that needs to be emphasized in this presentation. The Saudi FRAX came out in the year 2021, and over the time, people have realized that people after having fracture, they are not having very proper management of their bone health, if you like. There is deterioration of the amount of medication that is given to them, and an osteoporotic gap, if you like, has been realized after patient had their fractures. And there was a need to close this gap. So a new concept came out by the International Osteoporosis Federation, which is called the Fracture Liaison Service. And this is a service which is designed to protect the patient from future fractures. And I think Professor Munafoda is going to touch on this to a more extent. So in the interest of time, I have just given you this title so you are aware of this concept before Professor Mona's presentation. So really, some important achievements have been made typically in the last 30 years. There has been more public awareness, new treatments have been introduced, more awareness, more cooperation with other groups, and so on. I think that I will end up with this slide, and see people are asking what are the areas for improvement. And I think, in my opinion, the most important thing is to have credible data about osteoporosis in Saudi Arabia in particular, and credible data about osteoporosis fractures, because when you have these credible data, you can make good research, you can make good lines, and you can make credible fracs estimation. I think this is the first important step. I think secondly, there is no doubt that awareness, public awareness, and awareness among other health groups, including doctors, nurses, technicians, pharmacists, is very important. Implementation of guidelines, particular emphasis on the general practitioners, because these are the first defense in the management of osteoporosis. More cooperation with other groups, other societies, like the Clinical Pharmacy Society and the Orthopedic Society, endocrinology, rheumatology, and so on. So I hope that I have taken you in this journey over the years, from the days of the ancient Egyptians till now. And I think perhaps we can safely now touch down and waiting for the other journeys and flights that will be presented by my dear other speakers. Thank you so much.